Thank you. Good afternoon, everyone. My name is Ahmed Al-Hamadi. I'm a consultant of infectious disease at Tawam Hospital. And it gives me a great pleasure to introduce the next speaker, Dr. Jehad Abdalla, who's a consultant infectious disease at SKMC Al-Rahba Hospital in Abu Dhabi and head of Antimicrobial Stewardship Program Committee in Saha. The floor is yours.
Thank you very much, Doctor. Okay, so I'm going to skip the objectives for the sake of time. It's going to be clear. So let's talk about viruses' evolution over time. This is an old phenomenon. We know all the viruses are changing their genetic material. This is from very, very old time. And this is a normal phenomenon. And usually, if you keep evolving as a virus, either you get a better virus, a stronger virus, we call it more fitted virus, that has more ability to infect the cells, or a weak one, because most of the time it's a random selection, random phenomena of the evolution of the viruses over time. And for example, if we have a virus A, and this virus A had a mutation, and this mutation will affect the virus ability, for example, to, let's say, attach to the cell receptors. Later on, this might be interpreted as the virus will be more transmissible, causing more severe disease, and it might affect the efficacy of the vaccines, and sometimes affect the diagnostic tools, because we found some strains or some variants will evade the PCR testing, but not all of them. You know, the evolution of the virus, the replication, maybe I'll make it easier for you. As a copier machine, the virus in the cell will replicate in hundreds of millions of copies. For SARS-CoV-2, sometimes billions of copies. Okay, if you have a copier machine and will produce hundreds of thousands, millions of copies, every now and then you will have a defective copy, a bad copy. What happens if you take this copy and throw it away from other papers or copies? This defective copy is done, no more harm. If this defective copy is a strong copy, a very virulent, more fitted virus copy, and you keep it with other vulnerable people, you will allow this fitted virus to spread. This is what happened in certain countries. For example, in India, where the Delta variant started, there was a lot of gatherings, and one fitted virus, this virus that we call the Delta variant, had the chance to spread from one to another to hundreds of thousands, then millions, because of they did not apply the social distancing or physical distancing and the mask wearing. So the viruses in the SARS-CoV-2 variants of concern has the ability to affect, mutation affect the affinity to ACE2 receptors and the immune escape. This will result in increased transmissibility and more virulent virus. In fact, we have to know what's mutation and what's variant. Mutation is a single change in the virus genome, genetic code, while the variant is a group of viruses that share the same inherited distinctive set of mutations. As you can see, the Delta variant has the most alarming mutation, and one of them is the D614G. And any SARS-CoV-2 variant that has that mutation will result in more transmissible virus. In fact, this mutation took over very early, and it was present in every single variant started from June. As you know, the disease started, for example, in England in February, and imagine in June, this mutation was in every single variant we had. How do we name the variants? we go by Greek alphabet. So we start with alpha, beta, gamma, delta, epsilon, zeta, and hopefully we'll stop on what we have. We don't have to go to the omega by the end, inshallah. We have now variants of interest, we have variants of concern, and we have a variants of high concern. So let's start with the first one, the variant of interest. Those variants, as you can see, are affecting sporadic communities, maybe countries here and there, but it's not a massive spread. It can affect, of course, the transmissibility, it can affect the severity of the disease, the immune scape, but it's not widespread as we can see in the variants of concern. Those are having more ability to transmit, it has more ability to cause a severe disease, and of course, it can affect the social measures of such as vaccination or treatment modalities. So the difference is this is more potent, more spreading, and again, it's not only on sporadic community or different few countries here and there, it's everywhere. We go now to the variants of high consequence. Those, thanks God, we don't have any variants that fulfill this criteria. But if we do, we have to report it to the WHO and CDC. And of course, those have high effect on the diagnostic testing, the vaccine effectiveness, and reduce susceptibility to multiple emergency approved medications or therapeutics. And again, it might cause severe disease. Right now, no any variant fulfill this criteria, thanks God. Now, for Delta, as you can see, it accumulates most of the mutations, including, of course, the D614G, and this resulted in more transmissible disease and decreased neutralizing effect of the vaccine sera. What we do sometimes to check the efficacy of the vaccine, we get a blood from someone who received the vaccine, okay, and we'll mix it with the virus to see how much this antibodies in the convalescent plasma or blood from this recovered person or the vaccinated person can demolish and neutralize the virus. If it is efficacious, what happens? You will have all the viruses or most of the viruses killed in that tube. If not, this virus will not be affected, and the viral load or the number of viruses in that tube will be the same. So Delta has higher viral load compared to the previous variants, like 1,000 times more than previous variants. As I said, high affinity to receptor, the ACE2 receptor, and this resulted, as we mentioned, in increased transmissibility, severe disease, and change in the effectiveness of the treatment modality. And of course, the vaccines were affected, but we'll come to that later on. One very important message: if you are vaccinated and you get a breakthrough infection, which can happen, you will have a mild disease, and most of the people will not need to go to the hospital for admission. Most of them will not go to ICU, and of course, the death, the mortality will be way less than non-vaccinated people. This is clear. So you might get infected, you might get breakthrough infection, but this will be a mild disease. Delta variant compared to the old variant, the Wuhan, what you call Wuhan naive variant, is a big difference. Wuhan strain used to one infected person, if he's not wearing a mask, he's not keeping the social or the physical distancing, could infect 2 people, while Delta can infect up to 5 people. So as you can see, it is more transmissible. And in the US, this is from the US, in multiple states in the US, Delta started to show and be dominant by the end of June. And as you can see, the cases increased dramatically in June and July compared to the previous months. In fact, even if you are vaccinated, you might have, as you can see, Delta in the lower graph, Delta started to pick up in June while Alpha's variant went down. By the time Delta was the most dominant variant, the effectiveness of the vaccine was less. And this is regarding the two messenger RNA vaccines, the Moderna and Pfizer. If you think Alpha variant, the one started in England, was very transmissible, as you can see in this diagram, in October, there was minimal reporting of the Alpha variant in England. Through November, December, January, as you can see, in January, all the cases, almost 98 to 99% were Alpha. Now, imagine if Delta is 40 to 60% more than Alpha. How fast is it going to be spreading in one country or in one community to another? 50% more than what we're seeing here. Again, Delta variant, it can give you increased severity of the disease if you are not vaccinated. In one study, they checked how many people came to the emergency department, and this is comparing Delta to Alpha, the previous variant, and they found that people coming to the hospital with COVID infection, higher rate with Delta compared to the previous Alpha variant. And this is mainly on patients who are not fully vaccinated. People who are vaccinated can have less severe disease. Again, if you are vaccinated and you get a breakthrough infection, you will have two kinds of infection, either symptomatic disease, just a mild, maybe sore throat, cough, and it will go away, or severe disease. The rate of the mild symptomatic disease did not differ from unvaccinated people. We're good. But severe disease, big difference. When you compare people infected with Delta who got vaccinated with two vaccines, fully vaccinated, compared to non-vaccinated or one vaccine, big difference in ICU, in hospital admission, in ICU admission, and in mortality. This is a study done in England and published in New England Journal of Medicine, and it showed that only the modest difference between Delta and Alpha when it comes to vaccination, when it comes to severe disease. If you got two vaccines, when you got two vaccines, no difference. But if you get one vaccine or no vaccination, this is a big difference. Again, if you have two doses of the vaccine versus one, symptomatic disease, if you got two vaccines, there is no difference in Alpha and Delta. You're still protected. One vaccine, you're a big problem. Again, the same thing, two vaccines versus one vaccine. If you are vaccinated, fully vaccinated, you are protected from severe disease, admission, ICU, mortality, compared to one vaccine or no vaccine. The same thing here. If you got, no, here different. This is the symptomatic disease I told you about, the mild disease. I am fully vaccinated, correct? And I get a breakthrough infection, which can happen. What happens? Before, with Alpha, I can get a symptomatic mild disease, no need for admission. With Delta, no big difference. But if you are vaccinated with one vaccine, the same thing, again, no big difference. But one vaccine only, big difference with hospitalization and severe disease compared to the two. People who are immunocompromised have less response to the vaccine. And we know that, and that's why the CDC came with a recommendation that people who are immunocompromised receiving two shots of the vaccine, mainly messenger RNA, Moderna and Pfizer, should get a third shot. They don't call it a booster, they call it a third shot, and it should be within 4 weeks from the second shot. Finally, the effect on the Delta on monoclonal antibody, which one modality of therapy that we are using here in UAE, sotrovimab. The good news, no effect. The sotrovimab is still very effective compared to the other things, to the other ones, such as the bamlanivimab we used to use before. Finally, I have a few slides about vaccinated versus unvaccinated. And this is a snapshot from multiple hospitals in the US. I'm going to go through them, and it will tell you the difference between fully vaccinated and not vaccinated when it comes to admission and ICU. If you are fully vaccinated, the likelihood of getting admitted is very low, almost 10% or 20% compared to fully vaccinated. And the same thing here, even ICU or ventilation, fully vaccinated versus non-vaccinated, big difference. And another snapshot, always the vaccinated people, fully vaccinated, will have less severe disease, less need for admission, ICU, or ventilation. The message keeps going again in different hospitals. Being fully vaccinated means less admission, less severe disease, and mortality. Again, this is the comparison between Alpha and Delta when it comes to the effectiveness of the vaccine, and it shows the same results when you are fully vaccinated. When you are partially vaccinated with one vaccine, then you're not fully protected, and the rate of severe disease, need for admission, and ICU is higher. Now, this is the last slide, I believe. Again, this is if you are fully vaccinated, and as you can see, this is from US, when Los Angeles, when the Delta wave, Delta variant became the prominent variant in July and June, the rate of vaccinated individuals, fully vaccinated, rate of severe disease admission slightly went up, but compared to non-vaccinated, dramatic difference. And when they compared non-vaccinated, this is from Mayo Clinic, when they compared unvaccinated with vaccinated, and you see big difference. The gray line is the unvaccinated, the chance of having hospitalization and severe disease, and there was a slight difference between Moderna and Pfizer. Moderna was more protective, and we think this is because of two things. Moderna, the two shots are given within 4 weeks instead of 3 weeks, and the dose of Moderna is slightly higher than the Pfizer vaccine. This is when it comes to also hospitalization, and again, the same message, and ICU, the same message. Unvaccinated have a higher chance of going to the ICU, having severe disease and intubated versus unvaccinated, versus vaccinated. The last slide shows that if you are fully vaccinated and you get a breakthrough infection, you will clear your virus faster. This tells you 5 days, less than 5 days versus more than 5 days for vaccinated and unvaccinated. People infected with Delta variant who are fully vaccinated will clear their virus faster than non-vaccinated. How is this important? If you clear your virus and the viral load is less, means you are less contagious, less infectious. I guess this is my last slide. Thank you very much.
Thank you, Dr. Jehad, for this very well put together presentation. We don't have any questions from the virtual, but if you have any questions, I would like to ask you to kindly come forward to the microphones.
Thank you, Dr. Jehad. This is Corona coming for age group, all age group, young, adult, elderly. What about this infant and children? I'm not hear a lot of the mortality or any reason for that. And also, what about the vaccination for? We heard before it's less than 14 not allowed for vaccination, or more than 16, and why this like this happened?
The first waves and the first variants, we had more severe cases with older age. But you know, the vaccination campaigns all over the world started with high-risk group, mainly nursing home residents and older age. So Delta wave, when we had the Delta wave, the new variant, we noticed that the rate of younger population getting infected is higher. We don't know exactly if this is maybe a new characteristics of the Delta or because most of the old population are fully vaccinated. And I believe it's maybe because of the vaccine. Regarding the vaccine, we know that Pfizer vaccine is okay for any kids 12 years and above. Okay, and now we have the Sinopharm vaccine. If you are 6 years and above. So in UAE we have two vaccines. Sorry, four or three? 3 years and above. So anyone beyond the age of 3 is okay to get the Sinopharm. 12 years and above, okay to get Pfizer vaccine. And even other vaccines there's a lot of studies and they will approve younger age for vaccination.
Why like this difference? I mean, for about 3 weeks, 3 months or 4 months, they said only for 20 years, then now 3 years.
No, because they wait for studies. No one decides before studies, phase 3 and phase 4 studies. So once we have studies showing that it's safe and efficacious, safety is a very important thing, and efficacy of this vaccine. You don't want to give vaccine for nothing, correct? If we show it's efficacious and safe, then we'll decide, well, it's safe. Give it, for example, for Sinopharm, people above the age of 3 years old. And that's what we did. In China and UAE, we had a study and we showed it's efficacious and safe. The same thing for Pfizer. This is the normal step before we agree upon give the authorization for a vaccine or any medication.
Thank you, Dr. Jehad, for this wonderful presentation. What does the data tell us about Delta Plus? It came to the public attention that it could be a possible cause of increasing number of COVID infection recently in UK. So do we have any data on that?
Yeah, it's the only data we have so far that it's more transmissible, okay? The severity of the disease not proven yet. So if you are not vaccinated, again, it's a big problem with the Delta Plus. If you are vaccinated, I think from what I've seen, you're still protected, okay? And just a reminder, the Ministry of Health and DOH approved the 3rd shot of Pfizer for people who received the 2nd shot 6 months and more. Certain groups, of course, if you are above the age of 65, from 18 and above, but you have risk factors, or you're a healthcare worker, or you live in a long-term facility, or you live in a certain area with high risk of transmission. But for the Delta Plus, more transmissible, and this is a problem for unvaccinated group.
Okay, one last question.
Thank you so much. I just have a few questions to ask.
Just one question, please.
Very important questions. Which I choose, I don't know.
Just for the sake of time to move, because we're already, late for the schedule.
Okay, so regarding the third vaccination shot for the immunocompromised patients, you said that we better go for the messenger RNA vaccine. Is it regardless if they have received live attenuated vaccines for the 1st and 2nd shots?
Live attenuated vaccine?
Sinopharm.
Sinopharm is a killed virus.
Sorry, Sinopharm, killed vaccine.
Yeah, Sinopharm, we say it's 2 weeks. And the Department of Health Ministry of Health decided to give 2 weeks between all the vaccines. But CDC recently said that you can get messenger RNA with other killed viruses vaccines the same time. For example, influenza. The CDC said recently that you can get the influenza vaccine and the messenger RNA, Pfizer or Moderna, the same day each side. For Sinopharm, we're still studying that, but they say 2 weeks.
2 weeks following, yeah.
Yes.
So just like extended question regarding the same context. for the normal patients, for the normal persons who already received 2 doses of Sinopharm vaccine. Okay, it is recommended now to receive a 3rd dose of vaccination after 6 months.
Correct?
Is it only single shot or 2 shots?
Yeah, we saw a dramatic response to only 1 shot. In the beginning, we were allowed to get 2 shots of Pfizer messenger RNA vaccine after the 2 Sinopharm, the killed virus vaccine, correct? Then we did some studies and we found that the immunological response, the antibodies, the neutralizing antibodies for SARS-CoV-2 after 1 shot of Pfizer was really high and it gives good immunity. So that's why we decided no need to give a second one. And we've seen it in many patients.
Thank you.
Thank you.
Okay, thank you.